Okay, hi, I'm Zoe Pease. I am a physical therapist assistant and I'm certified in pelvic floor health and wellness. So this is going to be a presentation focused on getting some information out there to the public on pelvic floor physical therapy. And this is specifically directed at midwives, doulas, and home birth mothers, but we do have an OB trained nurse in the audience. Any questions are welcome at any time. We're going to try and keep this kind of conversational, so feel free to ask any questions. So we're going to start by going through, I'll give you just a quick rundown of everything we're going to be covering today. So we're going to start with just the basic anatomy of what is your pelvic floor. Not everyone even has an awareness of their pelvic floor. It's the floor of your core, it's very important. You're very lucky if you never think about your pelvic floor, because that means it's working correctly. We'll go over some basic anatomy. I'll use some analogies because I think that those are useful. I'm a visual learner myself. And then we're going to go through some common dysfunctions that can happen postpartum, which is what we're really going to be focusing on, is during pregnancy what the pelvic floor is doing, and then postpartum what physical therapy can do to help women. We're going to be looking at just a quick overview of what to expect with a pelvic floor physical therapy examination. I have my boss here, Ruth Scott, our owner of Physical, and our leader of our pelvic floor health and wellness section. Dr. Leah Folkner is here, so she will be able to answer questions at a little bit of a higher level than me. We're going to go over also the benefits of exercise during pregnancy, and that's a really important thing to look at when it comes to the pelvic floor working correctly, is making sure women can get back to the activities they enjoy without issues with their pelvic floor. I'm going to go over some resources, and we're going to look at evidence-based practice. So, what does the pelvic floor do? It's the floor of your core. It supports your pelvic organs. It helps to stop urine and to allow urine to flow. It has a sexual function, and it supports the baby during pregnancy as well as assisting in birth. There are fast twitch and slow twitch fibers that are in your pelvic floor muscles. So there's kind of a good example. I have a model here as well. So you can see your pelvic floor. There's multiple layers, and it's a muscle like any other muscle in your body. It contracts, it relaxes. So when we're looking at the fibers that control the pelvic floor muscles, we have fast twitch fibers and slow twitch fibers that are used for different functions. So when the fast twitch fibers are activated, that's where you get the quick contraction. So when you jump and you don't leak urine, the fast twitch fibers are working. So I'm going to give you an example of a soda can when it comes to the importance of the pelvic floor working in conjunction with your abdominal muscles and with your back muscles. So when everything's working properly, you have a strong system. When that can is just handed to you, you get a closed can of soda, it's strong. You can't crush it with your hands. But if you go and pop the top off, if you create some damage in that system, the whole thing can collapse. And it doesn't matter where that issue is being caused. It could be the pelvic floor at the bottom. It could be an issue with the abdominals. It could be an issue with the back. We're going to just briefly touch over that, but this is mostly going to be focused on pelvic floor. All right, so we're going to look at some normal pelvic floor function. Now, this is non-pregnant women. There are some changes in the pelvic floor muscles and how they behave during pregnancy, but that is mostly based on the increased pressure that's being put on the pelvic floor muscles due to the baby. So when we're looking at this, we're looking at normal baseline. A woman becomes pregnant. There are no issues yet. What should you be able to do normally? Well, you should be able to go to the bathroom around 6 to 8 times is when you should be urinating throughout the day. You shouldn't have to get up in the middle of the night more than 1 time. If it's more than once, that is considered abnormal. Now that may change during pregnancy as the bladder has less room to expand. So that we're not looking at here, we're looking more at baseline. And ideally, in an ideal world, we would get a baseline on women when they become pregnant and then make sure we're getting them back to that postpartum. And leaking urine is never normal. You should be able to control when you go to the bathroom. You should be able to contract and relax the pelvic floor muscles voluntarily. And there should be an involuntary contraction with increased abdominal pressure, what I was talking about before, those fast twitch fibers. When you jump, you shouldn't have to think about contracting your pelvic floor muscles. They should automatically do it. Yeah, and then we're gonna look at some abnormal pelvic floor functions. Leaking is the first one. Leaking is never normal. So when you laugh, when you sneeze, not being able to have that voluntary control is always abnormal. And that would be leaking during running, jumping, any increased abdominal pressure. And we're going to go on and look at the different types of urinary incontinence because they tend to be very common, but common does not equate to normal. If you can't hold urine, if you can't hold urine long enough to find a restroom, also abnormal. If painful intercourse persists longer than the recommended amount of time, according to Mayo Clinic, that's 4 to 6 weeks after giving birth. If pain persists, that is also abnormal, and that can be treated by physical therapy. So we're going to look at some good bladder habits and some bladder habits, and we look at this during the pelvic floor physical therapy evaluation. There are forms that patients will fill out asking about their habits with nutrition, hydration. We're looking to make sure that people are properly hydrated. Sometimes people are overhydrating, and so we'll have them keep a log for around 3 days to get a good idea of their habits. How often are they going? Can we use relaxation techniques to get people relaxed and able to hold their urine longer before they need to go? So you have a good handout on this that we're going to go over quickly. The one titled Bladder Habits. Sorry, that's okay. Are you Ashley? Oh. Yeah, we'll get you the notes here. Okay, I'm sorry. I actually don't think I have that one.
I'm bringing it to you.
You have that one. Okay, that was the one I didn't grab. So, yeah, we're going to go over the bladder habits one. So, I'm going to go over what is considered normal, and you guys are all going to be able to take this one home with you. Good habits, not going just in case. That's what I've included in there. So that's one thing we want to educate pregnant women on, is because when they're pregnant, their bladder has less of a capacity to hold urine. You want to break the habit of going just in case. Maybe they had to go every hour when they were pregnant, and maybe they don't need to do that anymore, and they need to let their pelvic floor get back to its normal function. So we're going to look at all those. Breath holding, creating a lot of excessive pressure can be damaging to the pelvic floor, especially when you're trying to do a Kegel exercise correctly. Because if you're creating a lot of intra-abdominal pressure, go back to that can metaphor I had before. If you're creating a lot of pressure, that can cause pressure on the pelvic floor and actually cause more stretching and more weakness. So it's very important that we're teaching women to perform Kegel exercises correctly and they're getting the proper contraction. So yeah, we look at everything. We want to treat people and women holistically. We don't want to just isolate one muscle group. And that's how we treat people in physical therapy across the board. They come in with, a hurt muscle, a torn quad. Well, you're going to start there, but then you're going to integrate it and you're going to make everything functional. So we want to look at the whole habit. Obviously, women will be caring for babies, so there's a whole different change to their lifestyle, and we don't want them to be thinking about finding a restroom every 30 minutes when they have a new infant to take care of. So habits are really important to look at. Now we're going to go into the pelvic floor physical examination. So I am not a physical therapist, I'm a physical therapist assistant, so I don't do this part, but I am educated and aware of everything that goes on, so feel free to ask any questions. If you're curious, Dr. Lee is here. She performs a lot of physical therapy, pelvic floor examinations. So first they're going to examine the pelvic floor from the outside. Everything is done with informed consent. We have models that we use, which I brought one today. And so the muscles are going to be observed from the outside. We're testing for nerve activity, for nerve response, and then they're going to test inside digitally, and they can actually feel, are the muscles closing properly around? They can pinpoint, is this muscle contracting properly? Is it not contracting properly? Is there pain? How sensitive is the area? Are the muscles underactive or are they overactive? So in issues of pain, and especially painful intercourse issues, there's a lot of tightness in the muscle, and this could be due to a scar that's left from tearing that hasn't healed properly. It could be due to incisions. During C-sections, there can be adhesions in the scar tissue that physical therapy can help break up. We do cross-friction massage to help break that up, and then we work with, and we'll go through some more products that we use to help with underactive and overactive muscles that can be used at home as well as in the clinic. So we use a biofeedback machine as well as testing the muscles. So the machine that we use is, we actually have it here, the Norvex unit, and it's a much more expensive unit than some of the units on the market. There are Prometheus units on the market, which are 2-channel. And this one is 3-channel, so you can see the top, bottom, and the lower one. So what we're testing for here is the top one is the muscle contractions that we see on the screen. We're testing the pelvic floor muscles, and then we're also testing external obliques, and we're testing the glute muscles. So I just want everyone, really quick, find the bony part in front of your hip, and then go about 1 inch towards your belly button. I want you to suck your belly button in towards your spine. You feel a muscle contraction there. Yeah, so that's where your external obliques. That's usually where we'll stick that unit, so we can record if there's any compensation, if the person is cheating with those muscles. Our bodies like to cheat a lot. And then also, if you sit up tall in your chairs, reach underneath, find the bony part of your bottom that's sticking out, and then squeeze your glutes together. That one's easy. You feel a contraction. I know you do. So you can see how you would cheat with those two things. So if a woman is laying down, instructed in doing a Kegel, she's instructed to lift and squeeze. Can you see how she might squeeze her glutes together or suck in her stomach if she doesn't actually know what she's doing, or if you can't contract those muscles? So this is a very sensitive unit, and we're able to get some very specific data, and then we can save that and refer back to it later once we start progressing that patient along. And as I was saying before, in an ideal world, we would get baseline measurement of this when a woman becomes pregnant, and then after the whole process of her pregnancy, after delivery, postpartum, then get a reading and be able to compare it, and ideally we would get her back to that baseline. So you can see here we have the electrodes that we use. I don't have any with me in person, but the pictures I think are pretty good. So those are the ones that we use externally, and then we have an internal probe that can be used. So this is based on patient comfort. There's a little bit of a cost difference too. Those need to be thrown away each time, the top ones, and those are stuck on either side of the anus, and they measure the pelvic floor contractions from there. And then the internal vaginal probe is inserted into the vagina, and then it is measuring the contraction of the muscles around. Yeah, from the examination. We're going to look at common dysfunctions that we find. So, I was talking before about the effects of the pregnancy on pelvic floor muscles. Even in natural, healthy childbirth, there can be tears, and there can be a lot of stress put on pelvic floor muscles. So we're going to look at what to look for and ask for. I'm curious what midwives look for and ask for, and hopefully in the comments below this video, I'll get some answers to those questions from professional midwives. what they're looking for in regard to pelvic floor function. Yeah, we're going to go over what physical therapy can do to help. And I want to stress, common does not equate to normal. Many women do leak after giving birth. And I think many women have been led to believe that because my friend does it, my other friend, leaks when she runs, it's a normal thing. Our company, we had a booth and we got to work at the Women's Health Expo here in Sioux Falls this last year. And I was very surprised by how many women, especially in their 40s and in their 50s, you would ask them, do you leak urine? And they just said, yep, of course. Like, it was the most normal thing. And then when I started talking to them about it not being normal and that there was something that could be done about it, there was a lot of excitement there. And I found that very eye-opening. So we're going to go on and look at some common pelvic floor dysfunctions. So the first one I want to look at is urinary leakage. So this is a big one. Like I said earlier, we're going to go over a couple different types. So there's urge incontinence, and that is where you just cannot hold your urine, and that is a lot of urine. So urge incontinence would be have an urge, can't suppress it, have to go now. And then we have stress incontinence. I'm going out of order here a little bit. That is the jump, leak a little bit. I go for a run, I leak a little bit. Those two can be mixed. So you could have some of one and some of both. So that would be problems with the slow twitch and the fast twitch fibers. And we also treat fecal incontinence, which is less common. I'll go over that briefly. When I was doing my research for this, I found a 2010 study that showed that 33% of women reported incontinence postpartum. And that is a big number. So there is a lot of importance in treating urinary incontinence early. There's another study that I found. This is in an article that I'm going to reference a couple times. This was put out by the PTA, the American Physical Therapy Association, and it said that the research shows that 80% of women, if there's pain or if there's urinary incontinence and it doesn't resolve itself in 3 months postpartum, it's not going to. The women who reported urinary incontinence at 3 months, 76.4 reported having it in 12 years. So if it's not treated early on, it's not getting better on its own. And where you really want to catch women is 3 to 4 weeks postpartum. So that quote, there's a little bit of debate on that, whether or not it is really normal, because I did say leaking is never normal. But 3 to 4 weeks is when you want to refer them to physical therapy. That's when it's a significant issue, when the pelvic floor has not returned to its normal abilities in 3 to 4 weeks. That's when your body needs some help. It needs some help training. And we're going to look at pelvic organ prolapse. I'm curious if professional midwives are testing for pelvic organ prolapse. No one here knows? Okay, hopefully. Comments below will answer that question. So that is another thing that's being tested for in a pelvic floor physical therapy exam. So the image I chose to give you a little visual aid for this is a bag of oranges. You can see if there was a hole put in there, if some damage was caused to that bag supporting the pelvic organs, and that's the uterus, the rectum, and the bladder. You could see how there could be some protruding. And that is what happens in pelvic organ prolapse. So there are 3 grades, grade 1, grade 2, grade 3, which is how we mark the severity of how severe the pelvic organ prolapse is. And a grade 3 is where one of those organs is descending outside the vaginal opening, which is quite severe. And we'll go over how we use exercise to help strengthen and take the pressure off the pelvic floor while we're strengthening those muscles. Pelvic pain and dyspareunia, which is the medical term for painful sex, can happen after the pelvic floor is damaged. So this can occur with tightness in the muscles. It can occur with myofascial myofascial tightness, and there's a study that I found that I'd like to read some of the information from. Find my slide here. Yeah, so like I said, 4 to 6 weeks waiting until intercourse for the first time after vaginal delivery is what's recommended by Mayo Clinic. Yeah, so the OBGYN and Neonatal Nursing Journal in 2012 estimated that myofascial pelvic pain in women may cause 14 to 23% of cases of chronic pelvic pain, and may cause up to 78% of cases of interstitial cystitis or unexplained bladder pain. So that's another very common and significant patient population that may not be treated. There can be a heavy psychological element to this. So we work on breathing exercises, relaxation techniques. We'll do work with dilators, and then also pelvic wands to help break up scar tissue, to release trigger points, which are tight spots in your muscles. And women can be educated to perform these release techniques at home, and then use dilators at home, as well as breathing techniques to help decrease the tightness in the muscle. So that's the overactive that I was talking about before. Underactive is more indicative of urinary incontinence, a lack of control, and overactive is often linked to pain. It's linked to a lot of tone, myofascial tightness, and possibly scar tissue. So there's a big importance in treating pelvic pain and catching it early. These are a couple quotes that I took, again, from that PTA article. So women who are having pelvic girdle pain early on in their pregnancies that isn't treated, it can often become quite severe in the 3rd trimester. So it's not going to get better if you just let it be early on in pregnancy. It's only going to get worse as the baby gets bigger. So 30% of women who have untreated pelvic girdle pain during pregnancy, later it can become chronic pain patients. And that can be very significant as well. Chronic pain is a difficult thing to treat. And after 6 weeks, somebody is... Oh, sorry, yeah.
Specific, can you show on your skeleton there, where is that pelvic girdle pain occurring?
So pelvic girdle pain, it can occur different places. But when we're talking about the pelvic girdle is kind of it's an umbrella term, so it could be occurring anywhere in the pelvic girdle. It could be occurring, it could be sacral pain, it could be pelvic floor itself, it could be muscular, it could be joints. Yeah.
And what part of the pregnancy are you seeing this occurring, or is it at any time, or is it in the 3rd trimester, or?
So yeah, pelvic pain, it can occur at any point. It can occur at any point in the pregnancy. What we're focusing on is that, or what that quote that I took from the article is talking about, is if it's not treated early on, there could be an issue with SI joint instability, and I'll go over SI DEL prescriptions later on, which we'll use in physical therapy. There can be issues with posture, the woman's posture during pregnancy, weakness in her hips, over-recruiting, the low back and the SI muscles. So your back is very related to your pelvic floor. We go back to that can analogy. And we treat everything from, early on in pregnancy to postpartum. I'm focusing a little bit more on postpartum, but yeah, we're seeing it. It could be all throughout pregnancy, but there is a benefit in catching it early. Yes.
You want me to jump in for a second?
Yes, please jump in.
Postpartum, where I see like painful intercourse, like muscular wise, I'll find it more in the transverse perineal muscles, as well as into obturator internus. So we work a lot internally on getting those muscles to soften and relax, and do some tissue work manually, and then I educate patients on how to do it themselves internally, and with some of the other tools that we prescribe. But that's usually where I'll see painful intercourse on
Yeah,
patients.
and what about,
Muscle groups.
when there's somewhat of a, urethral herniation?
I guess I haven't really come across that as much.
Okay,
So when they have more prolapse issues, then you would address the prolapse problem first, so that they can regain that to get into more of a normal position. Because sometimes that can be like where that urethral sphincter is what you're talking about when that starts to descend. I guess I see it more related to the cystocele issue when they have pain too. So then I'll prescribe proper positioning for their intercourse to reduce that type of descend that would be problematic to them. Proper exercise prescription, and then if needed, they might need a pessary or something as well, depending on the severity of the issue.
All right.
Does that answer your question?
Yeah.
Yeah. I'll go on to read off here too. So the risk of pelvic pain increases with multiple babies, hypermobility, it increases with body mass index, and or history of trauma to the pelvis. And the next we're going to move on to diastasis recti. I'm curious also if midwives are testing for diastasis recti. So it's quite easy. We're going to go over it in the next slide, how easy it is to test for it. So we'll test for that with women who have had babies, whether or not they have that. So that's the separation of your rectus abdominis, and that's your six-pack ab muscle. So during a pregnancy, there's some stretching that happens there, and there can be separation of the two halves of that muscle. So if you're able to fit 2 fingers into that separation, it's significant. And again, going back to that can model, if there's a compromise in that system, in the back, in the abdominals, in the pelvic floor, in the diaphragm, so we're looking at breathing too, there can be spinal instability. It may contribute to back pain. There could be a bulging in the abdomen if it's very significant. So we look at that, and we also treat that with exercise prescription, similarly to how we're treating the pelvic floor. So there's the test for it. It's pretty simple. You'll have the woman lay on her back, and then she's going to lift her head and her shoulders up off the table. And if you can easily fit 2 fingers in between that separation at multiple points, usually is where we're testing, then that is a significant issue that needs to be addressed. So we'll prescribe exercise holding those muscles together. We may use tape if it's very significant, especially if the woman needs to get back to physical activity to assist in holding those muscles together while they're healing during exercise. And then low back pain, very common. It can be related easily to posture, abdominal strength. So if you're getting diastasis recti, that can cause instability in your SI joint. It can also be related to your pelvic floor, everything's working together, and to fatigue. So if a woman has low back pain, it's kind of a vicious cycle with fatigue. She's tired, she's hurting, she's not paying attention to her body mechanics, and that puts a lot more stress on the low back. So we're going to go over some products that your physical therapist might recommend. So there's that SI belt, which I'm going to demonstrate right now. We have one here. Let's take off my sweater here. So there can be issues with SI joint due to the ligament laxity that happens, especially in the 3rd trimester of pregnancy. There was a patient I saw when I was a student, and this was a thing. She was pregnant with her 5th child, and she was getting pretty severe SI joint low back pain during her work, and this was the thing that got her to 0 out of 10 pain and back to her job while she was pregnant. So this can be worn over the clothes, under the clothes. There are special ones made for pregnant women that are much larger to provide more stability. So put it right around the SI joint in your low back, and then you'll tighten the straps to provide stability if there's weakness due to the ligament laxity there. And then there's a TENS unit, which people here may or may not be familiar with. They are using TENS units now during labor. So we wouldn't recommend that for a pregnant patient because it's inconclusive, the research, whether or not it can stimulate labor. So we wouldn't recommend that for a pregnant patient, but postpartum to help treat low back pain, and then also during labor to help treat that SI joint pain. And then we also work with exercise balls and bands. So again, if a woman is unable to contract her pelvic floor and do a proper Kegel, and we've tested that, sometimes we'll start with working her hip rotator muscles, which are very closely linked and related to the pelvic floor muscles. So we'll do exercises that are resisted with the ball held between the knees, either laying on your back, you could be sitting up, and then a resistance band put around your knees, working on the rotation in the hips and working those muscles. This is an inflatable wedge that we'll use during pelvic floor exercises if there is prolapse present. So if the pelvic floor muscles are descending, it's kind of the opposite of labor. Like, you don't want to birth uphill. Laying on your back, we've discovered, is the worst position for women to be in to give birth. When it comes to assisting the pelvic floor in healing with organ prolapse, it's almost exactly the opposite. We want to elevate the pelvis because you want to take the pressure of the organs off the pelvic floor while you're doing these exercises. So when I'm treating patients in the clinic and they have pelvic organ prolapse, they'll have their hips up on the wedge, usually knees bent, laying on a treatment table. And then, if appropriate, we'll use the ball and the band for resistance. And we'll work the hip internal, external rotators. And if there's a lot of pelvic floor weakness, that's where you're starting patients, is you're working the muscles that you know they can activate, and then working on activating pelvic floor muscles from there. And then we have more products too. So that is the pelvic floor wand that Leah was talking about, that we teach patients to use in the clinic and then also at home to help break up that myofascial tightness. It can be used to release scar tissue through the vaginal opening and into where the pelvic floor muscles are. Those right there are dilators that women can use in the clinic and also at home, and we have those here as well. We have the 3 smaller sizes here if you want to take a look at them. And then we have Kegel weights that women can also use at home. So those go up in weight, and the website that sells that specific brand has a lot of good instructional videos and articles that you can look at that teach you different exercises to do. So you may start by having a woman just laying on her back, contracting her pelvic floor, but then we need to make that functional, because you're not just laying on your back your whole life. You're up, you're moving around, you're lifting things. So those are tools that we use and that women can use at home to practice keeping that contraction while they're lifting or while they're doing a plie, because you have to contract your pelvic floor muscle when you're doing a plie. So can you contract it enough to hold one of those in and then move up the weights? There are a lot of exercise benefits during and after pregnancy, which we're also discovering. The kind of old recommendations of stay at home, rest, you're pregnant, are kind of going out the window now. We see women doing CrossFit pregnant, we see them running marathons pregnant. And there are a lot of benefits to that for the mother and for the baby. So if pelvic floor dysfunction is a barrier to women getting back to a healthy amount of activity, that is significant to quality of life. Okay, I'm going to move on to some resources that I have. So all the resources that I have, I'm going to link below the video. The first one is a book that we have available on our website. You can easily download it. It's 14 pages, and this is just across the board information on physical therapy related to the pelvic floor in any stage in life, because we treat everything in our clinics: men, women, children, all ages. So that's easily accessible. It's an easy read. And then I'm also going to link the APTA article that I took a lot of information from, and that's called What to Expect When They're Expecting. And they interview 5 clinicians who treat women postpartum and during pregnancy, and I think there's a lot of good information in there. And there's also a website where you can look to find, there's a database kept of Herman and Wallace, which are the leading physical therapists who are teaching pelvic floor physical therapy, and they keep a log of everyone who's been certified under them. Leah's been certified under them. So there's a website I'm going to link below where you can put in your address, and it will come up with a physical therapist who is certified in pelvic floor rehabilitation. So not all physical therapists are certified in pelvic floor PT. I was not taught a lot about it in school. I had to get a certification after school. We're lucky if we get a guest speaker. And most people that graduate physical therapy programs, it's kind of the same thing. They're lucky if they get a guest speaker. So it's very important to, if you're seeking out help in this area, to make sure that the practitioner you're going to is qualified. You can also call physical therapy clinics and check their credentials. The person at the front desk should be able to tell you whether or not they have someone there certified in pelvic floor rehabilitation. And then I'm going to call on Ruth to talk about the evidence.
Okay, so you have an article there in your packet that talks about the clinical practice guidelines. One of the things that has happened over the last couple of decades is that pharmacology has really been the go-to, as has surgery and mesh implants. And as we know, there have been some negative results with that, with people rejecting some of the mesh, with 50% of the cases, some research showed 50% of the cases then having to have it done again. You're hearing people have Botox, using filler to try to increase the bulk of the area, to try to passively control the flow of urine. But it comes down to, in the final research and the final recommendations from this article, the Annals of Internal Medicine, this is April 2019, we found information that talked about the efficacy of physical therapy. So they do say that pharmacology and non-pharmacology, which would be also physical therapy, are more likely than no treatment to improve urinary incontinence. So we do see improvements with these things. And behavioral therapy, especially in urge incontinence, is more effective than just having medication. So, but also with stress, but especially in urge incontinence. And then this article is where a lot of that information is held. And this talks about, and this is from another article from the American College of Physicians. So this isn't a physical therapy article, this is actually a physician article, and it gives these recommendations. And you have the abstract there. The first recommendation, and I know it's difficult to read up there, but the first line treatment for pelvic floor muscle training is pelvic floor muscle training. So that's physical therapy for people with stress incontinence. So that's the first thing that should be done, not a medication. And there was strong clinical evidence for that. The second recommendation is that for women with urgency incontinence, they need to go through bladder training, or behavioral training, which is what Zoe was talking about with taking the bladder diary, trying to increase the amount of time that they can wait, things like that. And then women with mixed incontinence, again, the third recommendation is that they needed pelvic floor muscle training. Recommendation number 4, against treatment with pharmacological agents for stress incontinence. And recommendation 5, yes, use pharmacology if they have urgency and the bladder training was unsuccessful. Then they're recommending a trial of 3 months before this is done. So not the first thing that should happen. They also recommend that we need to see women losing weight if they have urinary incontinence and developing an exercise program. And the problem with obesity and urinary incontinence has to do with abdominal pressure and, pressure on the bladder and stretching of the pelvic floor. Yes.
Is there any research with, because there's the obesity has become such a prevalent health issue, is comparable looking at any kind of stress and urinary incontinence pre-60s or pre-70s compared to now with the increase in...
I haven't been able to find anything like that. It wasn't routinely talked about or asked.
Yeah.
And one thing I do want to mention here before Zoe closes this is that the research also shows that if we do not ask them, they will not tell us that they have urinary incontinence. However, once we ask, boy, do they want to talk about it. So I think people don't know how to ask, and this is something we've got to educate all of our healthcare people about. As Zoe alluded to, we think it's normal, but it is abnormal. And prescribing pharmacology as the first line of defense to fix this is absolutely against the physician's own clinical practice guidelines. And I'd like to add that, and we could talk a little bit before we close about payment. Women often don't ever meet their deductible. This is one time that usually when you have a hospital-based birth, you probably will meet your deductible or your out-of-pocket max even, and this physical therapy to treat this wouldn't cost you probably anything out of pocket. And so I think it's a terrible shame that women aren't allowed to have a treatment with the biofeedback unit, because we know that if you do your Kegel wrong, if you're contracting your abdominals like Zoe was saying, or your glutes, you're pushing more pressure through the pelvic floor and you're going to become more incontinent. And so this thing of waiting until they're at least 3 months gone, they've done a lot of damage and actually made their pelvic floor a lot worse. So insurance does cover these treatments, and I'd like to see it be routine for every woman that has a baby. One treatment even, just so they can get on the biofeedback unit. And after we're done filming, if anyone wants to look at some actual examples of biofeedback treatments, we have 3 patients' biofeedback records here that you can see that have very different problems, and you can come up and look at the biofeedback unit itself. But if they could just get on the unit and see on the computer, by darn, I can contract my pelvic floor, or say, I really can't. So we know that half of the women that come in are not contracting their pelvic floor when they do a Kegel, including some of us that got on the unit during the training. So that was quite a surprise. But a lot of us were doing it wrong, and some of us did seek treatment after that.
Another question is, okay, we're talking postpartum here. However, I see women, talk to women. I work at long-term care, I have, and so many just do not have the incontinence. And so what do you look at later stages? You do PT, people go in, have surgery, people, are weak, the elderly, they're inactive, and you start them in a program. They gain strength, they gain balance, they gain so much. Is there any literature out there that talks about
Tons.
this occurring?
Thousands of articles.
To help, okay.
So when do we potty train a child? When they can walk. What happens as soon as you go into the wheelchair?
Yeah.
You lose continence.
Yeah.
And it's got to do with what Zoe was talking about. When you internally rotate your hips in and out during gait, you are lifting the pelvic floor. The obturator internus is working. one of the main muscles in the pelvic floor. And if you want to hold up that pelvis, or you want to show it, Leah. But they will become incontinent within 6 weeks in the wheelchair. So anyone who, it doesn't have to even be an older person, but if their pelvic floor is already weak, and that's where we see a lot of pain too. But so the roll for control exercises that Zoe had the pictures of, that ball and band up there, everybody in a wheelchair, everybody in a nursing home should be doing those. The number one reason for admission to a nursing home is urinary incontinence. Second thing is falls. And if you're rushing to go to the bathroom 8 times a night because you have urgency incontinence, you're probably going to fall. So these things are very related.
Right, yeah, and the research that we were talking about earlier, with if it's not caught 3 months postpartum, they have it within 12 years, or there's 78% that had it.
But even
12 years
that is
later.
reversible, or
Yes.
can be modified
Yes, it can
with
be
the
modified.
exercise program.
Right?
Yes, we'll see
And
patients
so
who are
it would be part of admission, part of protocol for health, elderly health.
It should be.
Yeah, the research says 80% of people can be cured or improved with non-invasive procedures.
And that's only the start. From there, then they can gain other health through the whole system, because they're more active, because they're getting stronger, and then we'll see the obesity. I mean, there's just, the impact of
It's all
there's just
related.
it's all related.
We see a lot of women limiting their activity because they're embarrassed of the incontinence.
And they're flowed into your bed. I mean, it's just, yeah. But we've got to educate physicians also that there is an option. It takes time, and to support the women in being able to say, yes, this is out there, and I mean, remembering to have that as part of even a care plan. Did everybody do your Kegels today? How are you coming? And evaluating continually.
It's a difficult thing, and I think we have to start by educating the women. It's been very difficult to get the physicians to change their tactic and move away from pharmacological treatment of this, even with all the evidence. But if women will ask, physicians, I have never had them say no. I've never had them forbid a person from having a referral. I think we have to teach the women to ask and to demand better care. And then I think the physicians will be re-educated and say this is important, but if we don't ask, they're not going to think of it on their own. Some of them are. We have some great physicians here that are asking about this and checking this. But inserting the finger vaginally and asking the patient to squeeze is not accurate enough to determine whether there is enough control to reduce stress incontinence, and that's been proven. So that is too variable, and we need to have something more objective, and each patient is different. So the good thing about this biofeedback, you want to hold it up, Zoe?
Yeah.
Because it's wireless, and she didn't mention this, but this is another reason this darn thing is so expensive. This one's $7,500. So we can put these little units, hook them onto the electrodes that just stick to somebody like that, and we can have them pick up the car seat. Is that when you leak? Let's find out. Is it when you rise out of the rocking chair while you're holding the baby? Okay, let's see what's going on. So this is a fancy EMG is what this system is. And that's why we want the cordless. We also work with a lot of dancers and cheerleaders. And we have young women, 16 to 20, that are embarrassed, but they have come to think it's normal that they will wet when they do a toe touch. And that's happening before they've had a baby. So what's going to happen here if we don't fix this now?
Right. And that's never expected, and so they feel really isolated.
Absolutely.
And it restricts their activity.
A lot of them quit because of it,
I didn't realize that.
Yeah, so that's why I thought if I'm going to buy one, we're going to get the kind that are wireless. Even with, it was interesting, Zoe demonstrated the plie, but we hooked some of our ballerinas up to this they typically have a very strong pelvic floor, and some of them even have some difficulty relaxing the pelvic floor during birth. But the plie activates the pelvic floor a lot. So even if somebody can't do a Kegel, if they do their plie, and they can do it, and the pelvic floor is contracted. So, and we know that because, and we can prove it to the patient by putting them on the machine and say, okay, well, you're not having the good luck with this Kegel. You know, we've tried it for, you know, an hour and you still can't do it. Sometimes we'll do e-stim to help them feel it. So that electrode that Zoe was showing, that electrode not only hooks up to this biofeedback, but it'll hook up to an electrical stimulator. Sometimes you need something to passively fire the muscle for you so that you can then remember, oh yeah, that's the pelvic floor. I haven't felt that, you know, I don't remember what that felt like to even contract that. Maybe some people have never contracted it correctly. And that might re-educate it, but if we can't get it going, we can at least start with the roll for control exercises and the plie, and we can have them hooked up and we can see what's going on in the pelvic floor. So we have some other tricks to get the pelvic floor working until we gain that motor control.
So you say insurance does cover this if to a degree, but I mean there's so many women, I mean lower income. I mean this is a health public health issue. I think.
Absolutely.
Seems like it. I mean.
Absolutely. Think of the
Because
expense. It's billions a year in pads.
Oh yeah.
Yeah.
Billions. And the number one reason for admission to a nursing home. So think what the burden is on our society for an issue that I don't even think it's embarrassing to talk about anymore. Maybe I'm becoming numb from it, from treating it for so many years, but I think it's the right of women to have this fixed. And I think it's crucial. And I think we have to continue to educate every woman that they don't have to stand for this and they have to ask for help.
Because it's life-changing when you do gain control. It opens up activities again. You can participate.
Absolutely. And do you have any more questions? If not, I'll just go on to saying a thank you to Educated Mommy for hosting this. And also, I want to say thank you to anyone who is taking the time to watch the video as well. As we just kind of had a discussion about, it's very important that the public has knowledge that there are treatment options out there. You don't have to be a healthcare professional to benefit from some information. Just you mentioning to your friend, your sister, somebody struggling with pelvic floor dysfunction issues, that hey, I watched a presentation on this, maybe you should look into physical therapy. That's all it could be. That would improve somebody's quality of life. So thank you for attending and thank you for watching.